Dear all, welcome back to NephroTube online nephrology lectures. In this lecture, I will talk about the updates of the management of focal segmental glomerulosclerosis according to the recently published KDIGO guidelines. As you all know that all lectures of NephroTube are available in the form of PowerPoint at the website nephrotube.com, and the recordings of all the lectures are available at our channel at YouTube NephroTube, and you can follow our Twitter account, Facebook page and Facebook group for more updates and activities. Regarding focal segmental glomerulosclerosis, I will start by the classification, the new classification, then the pathology, then the management. Regarding the focal segmental glomerulosclerosis classification, we have four types of FSGS. The primary focal segmental glomerulosclerosis, this is a case in which there is unidentified podocyte toxic factor that will affect the podocytes, causing diffuse food processes effacement that can be seen on the electron microscopy. And clinically, this patient will present with full nephrotic syndrome, which means that the patient will have a serum albumin less than 3 grams per deciliter and proteinuria more than 3.5 grams per deciliter. This primary FSGS, in patients with primary FSGS, there is no secondary cause or genetic cause, and this patient will be considered as primary FSGS. So, in primary FSGS, the patient has full nephrotic syndrome, and this patient may be treated with immunosuppressive drugs. The second form is the secondary FSGS. This patient has not full nephrotic syndrome, and this is the difference between the primary and secondary FSGS. Primary FSGS has full nephrotic syndrome, but the secondary don't have nephrotic syndrome. The patient may be presented by albumin more than 3 grams per deciliter in the blood and the proteinuria less than 3.5. Or the patient may be presented by low albumin in the blood, less than 3 grams per deciliter, but non-nephrotic range proteinuria in the urine, less than 3.5. Or the opposite, the patient may be presented by nephrotic range proteinuria, but with normal serum albumin. So, secondary focal SGS, the patient is not represented by nephrotic syndrome. The patient is not having the combined low serum albumin and the high level of protein more than 3.5 in the urine. And this patient shouldn't receive immunosuppressive treatment because in this patient, we must treat the secondary cause. Okay, genetic testing, genetic FSGS. When we may consider that the cause of FSGS is genetic. This will be considered in certain clinical situations, especially if there is a strong family history. So this may be a genetic FSGS, or if there is a resistance to immunosuppression, so it will be also there will be a possibility to be FSGS. And usually also the patient is presenting with non-nephrotic syndrome, or don't have nephrotic syndrome. The patient with FSGS, with genetic FSGS. So if it is with nephrotic syndrome, it is mainly primary. Non-nephrotic syndrome, it be secondary or genetic. If the secondary cause is clear, so it is secondary. If it is not clear and there is strong family history or resistance to immunosuppression, so it may be genetic. And finally, the last type of FSGS is FSGS of undetermined cause. It is an FSGS that is not primary, not with nephrotic syndrome, and no clear secondary cause, and no suspicion of genetic cause. So we will consider it as a FSGS of undetermined cause. The second, third, and the fourth type, these types shouldn't be treated by immunosuppression, only supportive therapy. But in the primary FSGS, we can treat with immunosuppression, as we will say at the end of this lecture. What are the causes of secondary FSGS? Multiple causes. We all know them very well, especially the HIV that's causing collapsing FSGS, cell parvovirus, a long list of the drugs. If there is a reduced nephron mass, this is because of glomerular hypertension, as if reflux nephropathy, and with normal nephron number, as in obesity-related glomerulopathy, and this is very common. And as we all know that FSGS may be the final consequence of any primary glomerular disease or renal disease, also secondary to diabetic nephropathy, hypertensive nephrosclerosis. So all of these are the secondary causes of FSGS. As we said, genetic forms of FSGS should be considered if there is a strong family history or if there is a resistance of immunosuppression. In this case, you have to make a genetic test for the patient, which is not available in most of the countries, and it needs special centers in FSGS with expertise, and mainly these patients must be involved in clinical trials. Regarding pathology, I will go rapidly through the pathology. This is the normal glomerulus. We have different types of FSGS, and these different types may point to the prognosis of the case or the response to the treatment. First type of FSGS is the perihilar. You will find the sclerotic lesion around the hilum, around the entry of the arteriole and afferent arteriole and the exit of the efferent arteriole. This is called the perihilar, and usually this points to secondary focal segmental glomerulosclerosis. So when you find in your pathology report a perihilar FSGS, you have to make an effort trying to find a secondary cause in this case. The second type is the tip lesion. The lesion is at the site of proximal convoluted tubule. This is called the tip lesion, and this may point to that this case will be steroid responsive. It has the better prognosis. The tip lesion, the tip variant sclerosis, is at the site of the exit or the formation of proximal convoluted tubule. The collapsing time, there will be collapse of all the glomeruli or the capillaries in the glomerulus, collapsing type, and this usually refer to a secondary cause, especially HIV and pamidronate, and also it points to a very bad prognosis of the case. And then the FSGS cellular, there will be endocapillary hypercellularity with occlusion of the capillaries, and finally the not otherwise specified FSGS type. In this type, there is no specific shape of the lesion, so the pathologist usually excludes the collapsing. If it is not collapsing, it is tip lesion. If it is not tip lesion, it is cellular lesion. If it is not, it will be the final focal segmental glomerulosclerosis, NOS, not otherwise specified. So we call it NOS, not otherwise specified, if there is no any other lesions of focal segmental are presented under the microscope. And as we said, each pathology variant may point to the prognosis and may be significant for a secondary cause. As we said, the perihilar points to that there may be a secondary cause. Tip variant, the better prognosis, better response for steroids. Collapsing, poor prognosis and response, and maybe secondary, especially to HIV and pamidronate. Cellular may be pointing to that it is an early lesion, early lesion, which may be the prognosis may be good too. What about immunofluorescence or immunostaining? You will find the non-specific trapping of IgM and C3 in the sclerotic lesion, and in the electron microscopy we said that will be food processes effacement, as there is an identified factor that affects the podocytes, causing their effacement and causing the proteinuria. What about the management? Again, as we mentioned in the minimal change lecture, here we will mention also the definitions rapidly of the different response status. Complete remission means that the proteinuria reduced less than 0.3 gram per day, and serum creatinine is stable, and serum albumin is more than 3.5 gram per deciliter. Partial remission, there is a decrease in proteinuria, but in the range between 0.3 to 3.5 gram per deciliter, and there is a decrease more than 50% of the proteinuria from the baseline. Relapse means that the patient had proteinuria after complete remission has been achieved, or there is an increase in proteinuria more than 50% during partial remission. Steroid-resistant FSGS, this will be considered if you tried steroids with the maximum dose for at least 16 weeks. So if the patient is not responding to steroids for 16 weeks, you will consider him as a steroid-resistant FSGS. Steroid-dependent FSGS, the patient responded well to corticosteroids, but there is a relapse during the glucocorticoid therapy or 2 weeks after completing the glucocorticoid therapy. Calcineurin resistant FSGS, we will consider that FSGS is resistant to calcineurin if there is no response to calcineurin for at least 4 to 6 months. So we consider the patient is steroid resistant if you tried steroids for 16 months and there is no response. And regarding calcineurin, we consider the patient is resistant after 4 to 6 weeks. And finally, CNI dependent, if there is a relapse, occurs 2 weeks of completing the CNI therapy for more than 12 months. So you have to continue the CNI treatment for more than 12 months. Okay. Let's go through the approach of the management. You have a patient with FSGS lesion on kidney biopsy. The first question you will ask yourself, is there nephrotic syndrome? Yes, if there is nephrotic syndrome, which means the patient has proteinuria more than 3.5 gram per day, serum albumin less than 3 gram per deciliter, with or without edema. Edema is not mandatory for the diagnosis of nephrotic syndrome in FSGS, and there is a diffuse effacement of food processes. So this is a likely to be primary FSGS, and this patient should be treated with immunosuppression. And if no response to immunosuppression, you have to consider it as genetic FSGS. As we said, we will consider the patient as genetic FSGS if there is strong family history or if there is resistance to immunosuppression. If the patient has no nephrotic syndrome, for example, the patient has nephrotic range proteinuria but with normal serum albumin, or the patient has proteinuria less than 3.5 gram per deciliter with or without hypoalbuminemia, so this patient may be secondary FSGS. You have to evaluate for underlying cause and exclude FSGS, and to consider genetic screening when appropriate, especially if there is a family history, to exclude genetic form. In this case, we will not start immunosuppression, only supportive therapy, and monitor proteinuria and serum albumin. Why? Because the patient proteinuria and serum albumin may be worsening, and we will consider him as primary nephrotic syndrome, as a primary FSGS. So it is not mandatory if the patient first presentation will be without nephrotic syndrome that it will continue in the same line. It may later have more proteinuria and less serum albumin, that you will consider it as a primary nephrotic syndrome, and it is a primary nephrotic syndrome. So you have follow up the proteinuria and serum albumin even if you considered it as a secondary or as a genetic 4, because the proteinuria may increase and serum albumin may decrease. Regarding the doses, the glucocorticoid initial treatment in focal segmental glomerulosclerosis is the same as in case of minimal change disease. You have to give the patient 1 milligram per kilogram. And for sure, I'm here talking about the treatment of primary focal segmental glomerulosclerosis. You have a primary focal segmental glomerulosclerosis, so you have to start immunosuppressive beside the supportive therapy. You will start by high dose glucocorticoid therapy in 1 milligram per kilogram per day, maximum 80 milligram, or 2 milligram per kilogram on alternate days, maximum 120 milligram. You have to continue the treatment at least for 4 weeks and for a maximum of 16 weeks. If the patient is not responding after 16 weeks, you will consider him as steroid resistant. A clinical tip that patients who are expected to respond to glucocorticoids usually show at least some improvement in proteinuria within 4 to 8 weeks. But you cannot conclude that the patient is steroid resistant except after 16 weeks. But there is a green flag or green light that the patient will respond to steroids if the patient shows partial improvement or some improvement within 4 to 8 weeks from the starting of the glucocorticoid therapy. And then glucocorticoid tapering gradually after the patient responds. And here is an important point that we mentioned also in the minimal change disease. Once the patient gets into remission, don't taper the glucocorticoid immediately, but you have to continue the glucocorticoids for 2 more weeks, then gradual tapering of the glucocorticoids. So to draw it, you started here the glucocorticoids, and at this point the patient gets into remission. Don't start tapering of the glucocorticoid gradually. Keep the glucocorticoids at the same dose for more 2 weeks, then start tapering of the glucocorticoids. This is a very important point that was mentioned in the minimal change disease and the focal segmental. Don't taper the glucocorticoid immediately after the patient enter remission. Continue them for 2 weeks, 2 more weeks, then taper the glucocorticoid. And this point wasn't mentioned in the previous old guidelines of KDIGO, and it was an expert opinion, but they mentioned it here in this. So what if the patient has a contraindication to use glucocorticoids, or if the patient is intolerant to glucocorticoids? So we have to use calcineurin inhibitors. We will use them as the same dose we used in minimal change disease, cyclosporin from 3 to 5 milligram per kilogram per day in 2 divided doses, or tacrolimus from 0.05 to 0.1 milligram per kilogram per day, with a trough level target in cyclosporin from 100 to 175 nanogram per ml, and for tacrolimus from 5 to 10 nanogram per ml. Don't consider the patient is resistant for calcineurin inhibitor except after achieving a target trough level for at least 4 to 6 months, as we mentioned in the previous slide of definitions. Don't consider the patient not responding to calcineurin inhibitor except after achieving the target trough level for at least 4 to 6 months, and don't stop the management with calcineurin inhibitor, or by another way, continue the treatment for calcineurin inhibitor for at least 12 months to minimize the risk of relapse. What if there is relapsing primary focal segmental glomerulosclerosis? The patient must be treated with the same approach as relapsing minimal change disease. You will repeat the glucocorticoid therapy, and if there is contraindication to the glucocorticoid therapy, you have to use an alternative to the glucocorticoids, which are calcineurin inhibitors. What if the patient has steroid resistant primary FSGS? from the start. You will start cyclosporin, it is the only alternative, or tacrolimus with the same doses we set in the initiation. Here we said previously we said in the initiation that we will use glucocorticoids, and if the patient is not responding to or if there is contraindication to glucocorticoids, we can start by calcineurin inhibitors. Also, if the patient is resistant to steroid, we can start by calcineurin inhibitors with the same criteria and dosing protocol that we used in the initiation of calcineurin inhibitors in the initiation for the resistant cases. What if the patient is intolerant or not respond to calcineurin inhibitor? There is a very weak evidence that you can use MMF with high dose dexamethasone, rituximab, ACTH, and usually these cases better to be referred to expert center of focal segmental glomerulosclerosis and better to be involved in clinical trials. So, adults who have steroid-resistant primary FSGS with resistance or intolerance to calcineurin inhibitors should be referred to specialized center for consideration of rebiopsy, alternative treatment, or enrollment in a clinical trial. Finally, what are the risk factors for progression of focal segmental glomerulosclerosis? For sure, the severity of proteinuria, the kidney function, black race, the collapsing variant, or if there is tubulointerstitial fibrosis, and failure to achieve partial or complete. Thank you for watching this lecture and see you in the next lecture.